Welcome to Dr. Balaga's God Knowledge Doc podcast, your quick dive into the latest medical breakthroughs to keep you ahead of the curve. Let's get started. Today, July 14, 2025. This video is on a recent JACC article titled Plaque Vulnerability and Cardiovascular Risk Factor Burden in Acute Coronary Syndrome. And there's an accompanying editorial in the same issue of JACC. Cardiovascular risk factors like diabetes, smoking, high blood pressure, dyslipidemia increase adverse outcomes. The relationship between cumulative cardiovascular risk factors and plaque vulnerability are unclear, so the study authors used optical coherence tomography to examine this link in ACS patients. The study cohort comprised of 1,581 patients with ACS from 3 registries, 2,187 plaques, 1,581 were culprit plaques and 606 were non-culprit plaques. They stratified them by 0 to 4 risk factors. Optical coherence tomography was used to identify features including lipid-rich plaques, thin-cap fibroatheromas, macrophages, microvessels, and cholesterol crystals. They used statistical tools including Kruskal-Wallis models and models for clustered data. What did they find? A total of 2,187 plaques were analyzed. 1,581 were culprits, 606 were non-culprit. In the culprit plaques, prevalence increased with risk factors. Lipid-rich plaque, the p-value was 0.027. Thin-cap fibroatheromas, p-value 0.006. Macrophages, p-value less than 0.001. Microvessels, p-value less than 0.001. Cholesterol crystals, P equals 0.032. When 2 or more risk factors were independently associated with thin-cap fibroatheromas, odds ratio 1.41. Macrophages, the odds ratio 1.54. Microvessels, odds ratio 1.38. And cholesterol crystals, an odds ratio of 1.35. Plaque rupture was more common with more risk factors, p-value 0.015. Plaque erosion decreased with more risk factors, p-value 0.001. In non-culprit plaques, only macrophages and cholesterol crystals correlated with risk factors. That is, the non-culprit plaques showed weaker associations. What are the key takeaways? More cardiovascular risk factors, higher plaque vulnerability, and likelihood of STEMI. Smoking showed specific link with lipid-rich plaques. These findings support multifactorial risk convergence, emphasizing the need for aggressive risk modification. The accompanying editorial, the key message was in the editorial, ACS often stems from plaque rupture or erosion, not just luminal narrowing. Imaging, including optical coherence tomography and IVUS, shows features like thin-cap fibroatheromas and macrophage-rich plaque as high risk. In the editorial insights, where this study confirms that greater than 2 risk factors, that is diabetes, smoking, hypertension, and dyslipidemia, was equivalent to more vulnerable plaque features. There was an inverse relationship with erosion. Erosion often occurs in lipid-poor inflammation sparse plaque, the NSTEMIs. So the STEMIs were more associated with plaque rupture and multiple risk factors. The key takeaway from this editorial was 75 years of epidemiology converge with imaging. Risk factors drive plaque biology. Intensifying prevention targets vulnerable plaques, not just obstructive stenosis. One of the key takeaways of this article is plaque erosion. These findings clarify the bifurcated pathology of acute coronary syndromes. Risk factors drive rupture-prone plaque biology. Plaque erosion represents an alternative pathway potentially identified by non-traditional factors. Example, pollution, endothelial shear stress, sex hormones, or microbiome. The key insight is precision prevention must address diverse plaque biology. Traditional cardiovascular risk modification may not reduce erosion-based acute coronary syndromes. If you enjoyed this episode, share it with your colleagues. When we change how we see disease, we change how we shape lives. Until next time, stay curious, stay compassionate, and keep seeking wisdom. Podcast brought to you by Master MedFacts at mastermedfacts.com.